All right, we're going to get going. I'm going to come over here and talk to the most dense crowd here. Welcome everybody to Grand Rounds. We're really excited to have the speaker today. If you would, you have the CME MOC request form there. Please take a photo of that and get your credit. I just did mine. Today, we are very excited to have Dr. Silpa Krefft join us today from the VA hospital. Dr. Krefft is going to be talking to us about respiratory effects after military deployment, not something that we commonly think of, and I think is going to be a really fascinating lecture for us to learn from her and her work in this. Dr. Krefft went to medical school at the University of Texas in San Antonio. From there, she went to Boston University, where she did her residency and chief residency. We were fortunate to attract her back here, where she joined us as a fellow in pulmonary critical care medicine. She did that for 3 years, started an MPH there, and then decided to continue to do more residency and went into an occupational medicine residency after she finished her fellowship in pulmonary critical care. And she did that for 2 years and then joined us on faculty thereafter. For a number of years, she worked both at National Jewish and at the VA, and she's currently on a Career Development Award at the VA, developing a cohort to study occupational or lung effects after military deployment. She's spoken locally, regionally, and across the world on deployment-related respiratory diseases, occupational lung diseases, and also air quality. It is our pleasure to join Dr. Krefft today, and thank you for coming.
Oops. Thank you so much for that introduction, Dr. Eddy. I am just really thrilled to be here this afternoon to talk to you all about really an emerging set of conditions known as deployment-related respiratory diseases. Over the next 50 minutes, I'll be speaking to you all about burn pits as well as other hazards and the respiratory health effects that have been described to military service members and actually civilian contractors returning from Iraq and Afghanistan. Our understanding of this group of exposure-related respiratory diseases is still unfolding, and we hope that with increased recognition and multidisciplinary approaches, including team science, that will continue to advance our understanding of this emerging set of conditions. Oh, sorry. Okay. So before we get started, here are my relevant disclosures. Funding for my work includes a Career Development Award at the VA, as well as work on a Department of Defense multi-site clinical trial and deployment-related asthma. Also, my work at the VA, our site has received funding for creation of a VA-based post-deployment cardiopulmonary evaluation network center. So opinions, interpretations, conclusions, and recommendations are my own and are not necessarily endorsed by the Veterans Administration or Department of Defense. I'll start with the aims of today's talk. I'm hoping that after today, you'll have a better understanding of military occupational exposures, relatively recent legislation known as the PACT Act, some epidemiologic studies, and then also the definition of something called deployment-related respiratory disease, or what you'll hear me refer to as DRRD. We'll talk a little bit about recommended diagnostic testing, a little bit about treatment, and then resources that may be helpful as you see patients who may either have or be at risk for DRRD. So here's a case that may represent what's coming your way in the near future or that you may already have encountered in clinic. So this is a case of Mr. G, who is a 38-year-old male never smoker who presents for a follow-up visit after initial consultation and a prior follow-up visit with you a few months ago. You previously diagnosed him with asthma and chronic rhinitis based on pulmonary function testing that showed reversible airway obstruction and a significant bronchodilator response. The patient also had a normal chest X-ray and a normal CT scan. He reports that symptoms are improved with his current medication regimen of a LABA, an inhaled corticosteroid combination, and short-acting beta agonist. And he has an asthma control test score of 21, which is higher than 19, indicating reasonably well-managed asthma. However, his main concern today is that he wants to know if his chronic rhinitis and asthma are related to his previous exposures to burn pits during military deployment to Iraq in 2007, 2009, and 2011. So I'm just going to stop here for a second and just, and hopefully you can think about this, but what would you tell him? And maybe this has happened to you in clinic. So just thinking about that. So you could actually tell him that the VA has recognized several respiratory conditions that are presumptively related to military deployment. In 2021, the VA secretary announced that a veteran military service member who had deployed to Southwest Asia, so that includes Iraq and Afghanistan, and other nearby countries, if they had been diagnosed with asthma, rhinitis, or sinusitis, these conditions were to be considered service-related and more specifically related to Southwest Asia deployment and particulate matter exposure. So then fast forward to the summer in August of 2022, and you may have heard the comedian, entertainer Jon Stewart, some veterans organizations, and U.S. congressional members discussing something called the PACT Act. Oops. So the PACT Act is abbreviated from its longer title, the Sergeant First Class Heath Robinson Honoring Our Promise to Address Comprehensive Toxics Act, or what you'll hear me refer to as simply the PACT Act from here on out. So what is the PACT Act? So while the PACT Act actually addresses a number of military exposures from multiple conflict eras, even going back to Agent Orange, as well as some domestic exposures, there's a lot of emphasis on Southwest Asia deployment. So what's really been happening overseas in the past 30 years. And that's really what I'm going to focus on. But near the end of the talk, I'll give you some resources if you do have questions about other, important military exposures. But basically, through the PACT Act, the VA has added more than 20 burn pit and other toxic exposure presumptive conditions. And so this change expands benefits for Gulf War era and post 9/11 veterans who have deployed to Southwest Asia that includes several countries in the Middle East as well as neighboring areas. So these cancers are now considered presumptive conditions. You'll notice on here that glioblastoma is also listed. And this legislation has been something that has been near to President Biden's, personal experience, as he had lost a son who had deployed to Iraq, who died of glioblastoma. So had he still been living, he would have been covered under this PACT Act as having a military service related cancer. So while data still there's lots of robust data showing a link between cancer and these exposures, given the significance of these conditions and a need for veterans to get into care, this legislation was passed while awaiting further research studies. So, this expansion through the PACT Act also covers a number of respiratory illnesses that are now considered presumptively service-connected. So any of the respiratory conditions that you see on this slide, asthma, COPD, interstitial lung disease, pulmonary fibrosis, sarcoidosis, some of which have really more data showing a link between military deployment exposures and disease than others on this list, and we'll go through some of that. But all of these are now considered presumptive service conditions. So that's really the state of where we're at now. So if you had a veteran or you were seeing somebody in clinic, as a number of veterans seek care outside of the VA healthcare system, I think this is helpful to know that you may have a patient who's eligible for benefits. So now you might be wondering, well, how do we get here? So I think we have to answer a couple of questions, or at least review some of, how we got to the place that we're at in terms of legislation. So I think that starts by asking things like, what do we know about military deployment to Southwest Asia, including Iraq and Afghanistan? What are some of the exposures of concern? What is a burn pit? And what do we know about health effects? So let's take a look at the past 30 years to get a better understanding of all of this. So over the past 30 plus years, more than 3.5 million people have deployed to Southwest Asia and nearby regions. While the vast majority have served in the military, we have sent over a number of civilian contractors as well who've deployed in support of these military operations. And our United States military personnel and contractors have deployed not only as part of several military operations, but also peacetime operations, as well as you can see depicted on this timeline. In fact, just over a year ago, we had sent another 1,000 military personnel from Fort Carson to Southwest Asia. So although major military operations have really, been drawn down or ceased in places like Afghanistan, we still do have a presence in these regions. But what's really gotten us to take note of military deployment and the possibility of respiratory disease is the significant number of service members returning from deployment who are unable to meet physical fitness requirements, sometimes resulting in early medical retirement and an abrupt end to their military career. And the most commonly reported symptoms include dyspnea, cough, wheezing, and chest tightness. So it's caused both veterans and the scientific and medical community to ask if these exercise impairments and respiratory symptoms are related to something in the air. Which leads me to give you an overview of common exposures encountered during deployment. So deployment to Southwest Asia locations, as I'd shown you on the map, is associated with complex inhalational hazards that may include burn pit emissions, but also many other inhalational hazards that you can see here on this slide that include fires, smoke, diesel, combat dust and debris as well. You can see examples of the first two hazards in the pictures on this slide. First, if you look at the top right, you will see a bulldozer spreading out debris and trash in a so-called burn pit. A burn pit's an area where trash generated by military operations is disposed of and burned. This can range in size from, just a small square to the size of a football field or greater. The image at the bottom right shows a sandstorm rolling into a military site. So deployed personnel also report exposures to a number of other hazards, as you can see outlined on this slide. So I'm going to take you through a couple of pictures, but this is just the dust that's generated from a helicopter taking off. This is in the Helmand province of Afghanistan. So, our personnel are often deployed to pretty austere regions in Southwest Asia. You may not think that a combat medic has a lot of exposure risk in terms of taking care of patients medically, but if they're doing a dusty medical evacuation like this, you can see that they're exposed to some very poor air quality. And then while there were shared exposures during the first Gulf War era and post 9/11 era, the 1991 oil well fires were widespread for a period of several months during 1991. So apart from some of the exposures I already mentioned, oil well fires were something that were really described in more intensity during the first Gulf War era. Oops, sorry. Here we go. I think I just skipped to, okay. So another relevant exposure is the World Trade Center collapse, in that first responders and bystanders were exposed to dust, debris, and smoke. And this is really, I would say, sorry, I keep flipping. Okay. We've really seen some comparable exposures with the World Trade Center collapse cohort. One strength of the World Trade Center collapse related research is that pre-World Trade Center lung function data was available for most first responders. So although many still had normal lung function following the World Trade Center collapse, there was an average of nearly a half a liter decline in FEV1 in just 1 year after the World Trade Center collapse. That's definitely a pretty significant decline. So people may have been going from super normal to still in the normal range. So keep this in mind over the course of this talk, as current military occupational surveillance does not involve conducting routine pre and post deployment lung function testing. This is maybe an exception in some particular job duties, such as Air Force firefighters. Looking at the World Trade Center collapse cohort also, you'll see that there are some similar health outcomes that I'll review here, where these outcomes have included increased World Trade Center cough, asthma, COPD, gastroesophageal reflux disease, sinus disease, sarcoidosis, and PTSD. So now moving back to deployment-related exposures, one particular concern for service members has been that of burn pits. So this prompted the Institute of Medicine, which is now known as the National Academy of Sciences and Engineering and Medicine, to evaluate the potential for long-term health consequences for burn pit exposure. And what we've basically learned, so there was they convened a committee that really spent a special focus on the burn pit at Joint Base Balad, which is a notoriously large burn pit, no longer, in use, but that was described as always having a plume of smoke, and was one of the ones that was most notable with many veterans as they returned back from deployments. This report, unfortunately, just highlighted the research gaps. They mentioned that there was a lack of exposure data, both personal exposure monitoring and area sampling, and also suggested that exposures may be more complex than burn pits only. So thinking about burn pits did not really give a complete picture of the hazards that were being encountered during military deployment. So the committee recommended further exposure and health outcomes research with a focus on long-term health effects. But what we can conclude from this, and what was summarized here, was that multiple studies were documenting increased incidence of respiratory complaints in veterans of the 1991 Gulf War and also the post 9/11 era conflicts in Iraq and Afghanistan. So beyond burn pit emissions, many have asked, what is in the air? Limited data exists and no published personal exposure monitoring data are available. However, in the past, the Department of Defense conducted a large air sampling effort from 2006 to 2007 across 15 military bases. You can see on the y-axis of the figure on the left that this represents a cubic meter concentration of particulate matter 2.5, or particles that are 2.5 micrometers in diameter or less. And then the horizontal lines here show the thresholds for both the military exposure guideline for PM, and then also the 24-hour EPA standards as well. And what you can see is that all sites exceed the military exposure guideline of 15 micrograms per cubic meter of PM. And there are three main air pollutants that include geologic dust, smoke from burn pits, and then metals, especially aluminum, cadmium, and lead in the PM 2.5 fraction. So as you can see, there are many sources of PM 2.5 in the deployment environment. So we're going to spend a little bit of time on this slide. Now that we've talked about exposures, we're going to move on to symptoms and health effects. Starting as early as 2004, there were reports of increased respiratory symptoms in men and women who had deployed to Southwest Asia. The Millennium Cohort Study, which I'll mention soon, when still in its infancy, found a 1.7-fold higher rate of respiratory symptoms in deployed versus non-deployed military personnel that was independent of smoking in over 46,000 participants. So as we think about the respiratory tract as a target organ, it's helpful to think about the upper respiratory tract and the lower respiratory tract. And this one of the first studies was this case control study that reported increased rates of allergic rhinitis symptoms. But that same study actually showed asthmatics and non-asthmatics reporting increased respiratory symptoms with deployment, and increased odds of asthma if deployed. And then moving on, this second study was actually a retrospective case series from Landstuhl Regional Medical Center, where many veterans or many military personnel may seek further medical care, especially if it cannot be managed during a deployment in a particular region. And over 40 active duty military personnel were diagnosed with vocal cord dysfunction or laryngeal dysfunction there. In terms of lower respiratory tract, as early as 2004, there was a rash of acute eosinophilic pneumonia in Iraq over a 13-month period. 2 out of 18 individuals actually died from this condition. And so the U.S. Army Public Health Command actually sent a group to conduct an epidemiologic investigation, and really had noted new onset smoking as well as reported exposure to fine airborne dust particulate matter, just raising the concern about this environment and potential interaction with the lung. Fast forward to 2009, and over 45 cases of acute eosinophilic pneumonia had been diagnosed in this population. And from what I understand now, well over 100 since that time. And then moving on to asthma, I'll highlight one of these studies on another slide pretty soon, but this is probably where we have our strongest signal. And some of that may be that asthma has a little bit more of a clear and consistent case definition, and maybe is an easier outcome in some of our previous studies to have actually assessed. And then the last study I'm going to bring up, I think is important because while there are some clear diagnostic criteria for some of the upper airway disease like laryngeal dysfunction and sinus disease, as well as asthma, there have been a substantial number of veterans and active duty military personnel who had respiratory symptoms and either had normal testing or subtle abnormalities that didn't really quite fit a diagnosis. And so after going through pulmonary function testing, chest imaging, in some cases methacholine challenges and cardiopulmonary exercise testing, they were really left without a clear diagnosis. And in some cases, really career limiting, career ending symptoms. So really a sentinel paper was published back in the New England Journal of Medicine in 2011. And this was a look at the 101st Airborne unit in Fort Campbell, Kentucky, who had sought care at Vanderbilt Medical Center for unexplained shortness of breath. In this case series, 80 military personnel were actually evaluated. The median age was 33 years old. 66% were never smokers. Many of them had normal testing or just subtle abnormalities on test and had undergone extensive non-invasive evaluation. While most of us would have patients return, for follow-up or potentially say, come back and see us, if things get worse, seeing 80 veterans who are young, who were previously very healthy, I think really raised some concerns and gave the pulmonary team there some pause. So they did what at that time was considered a controversial step and referred patients for surgical lung biopsy. But that not all of the patients actually underwent lung biopsy, but of the 80 who were seen, 49 underwent a surgical lung biopsy, and 38 had small airways abnormalities identified as constrictive bronchiolitis. There were a few cases of sarcoidosis and hypersensitivity pneumonitis also identified. But I think this really puts something on the map that you could have all this non-invasive testing, but still have disease. And especially when symptoms were out of proportion, that small airways abnormalities that are often missed on CT scans and lung function testing, which are really better at picking up large airways abnormalities. It really kind of highlighted that some of our testing was still not enough, and that people may really be at risk for some other conditions. So with all of that, personal exposure monitoring data and then quantitative monitoring data haven't really been available. And trying to make these links between these health outcomes and these exposures has been difficult. So as a scientific community, we've had to rely on retrospective exposure assessment. So I'll talk a little bit about some of the efforts that have been taken to really understand exposures in the absence of some of that real-time monitoring. So our team, led by Lauren Zellbaron and Cecile Rose at National Jewish Health, tried to tackle this issue by estimating inhalational exposure intensity. So we decided to look at something called military occupational specialty codes. Previous occupational lung disease research has found utility in occupational specialty codes or specific industry categories in predicting hazard risk for occupational diseases. Seeing a major gap in the literature, our team looked at the utility of these MOS codes. So MOS codes are assigned to all personnel by the Department of Defense. These are alphanumeric codes used to describe job training and duties. For example, in the Army, 11 Bravo is the code to designate job classification for infantry. You can see here that the job duties include tasks that are heavily ground-based. So I'm not going to show all the data here due to time constraints, but essentially we found that combat MOS codes were linked to the highest mean respiratory hazard exposure intensities and to likelihood of having undergone clinical evaluation for respiratory symptoms. However, non-combat codes are not reliable predictors of exposure risk. So consider the case of a chaplain serving in the Army. Job duties of a chaplain include providing advice in matters pertaining to religion and overseeing religious ministries and other related programs. However, during deployment, job duties can vary considerably, as the Army chaplain often accompanies soldiers during combat missions and is likely exposed to respiratory hazards. Another example includes a cook who functioned as a gunner during deployment. Once deployed, personnel often are assigned to job tasks or have additional responsibilities wherever needed. In summary, combat MOS can be a good predictor, but we have to be careful about inference of no risk in those without a combat MOS. And although we have been tackling exposures, the VA may be in a better position now to continue this work through some of the studies that they have that are ongoing. Oh, sorry. So I also want to mention, I wanted to mention these two ongoing VA cooperative studies that have the ability to provide more insight into estimating exposure and looking at population-based outcomes. So the first one on the slide is the CSP 595 study, also referred to as the SHADE study. And it is being conducted at 6 VA medical centers across the country with the plan to enroll over 6,000 veterans. The plan is to characterize the impact of deployment-related respiratory particulate pollution exposures during Southwest Asia deployment and continuing operations on current pulmonary health. Utilizing some of the NASA satellite data, they are creating spatial temporal exposure grids of estimated environmental PM 2.5 levels during deployment. So keep in mind, this is good at getting aggregate exposure, but maybe not short-term exposures. Like from a blast, but this is pretty good considering what we have to work with now. Then the plan is to link the exposure grid with an individual's location and duration, and then sum their particulate matter exposures, with plans to assess association with health outcomes, including looking at things like asthma. Then the bottom study, the Millennium Cohort study, I actually had mentioned some of the references I had on an earlier slide included studies published from the Millennium Cohort. And really, the goal is to determine how military-related experience affect long-term health of military service members. It's not limited to respiratory health outcomes. The study commenced in 2001, and it's really a DoD and VA partnership. To date, they have enrolled over 250,000 study participants, and they're still enrolling participants. So the nice thing about this is that you have a large amount of data. However, it's not a deep dive, or you're not going to necessarily have deeply phenotyped individuals or study participants. However, with continued efforts to try to link this with longitudinal data and VA health records, this may become a more powerful tool in the future. And there are opportunities for VA investigators and non-VA investigators to utilize this data. So despite a number of studies that I think are really compelling, the National Academy of Sciences was asked to look at this question of respiratory health effects and airborne hazards again. And in 2020, they looked at studies where they were set up where you could actually assume some type of causation based on the study design. So that really left out a number of observational studies. And based on that, they concluded that there was really insufficient evidence of an association between exposures and respiratory health effects. But they cited a number of things that were really hampering that conclusion. One was lack of good exposure characterization, the lack of the exposure data. Also, the lack of clear and consistent case definitions was something that was also of concern. Respiratory symptoms, but maybe not disease diagnoses, were being used to look at some of these outcomes. So they encouraged improvements in that, and also to strengthen a DoD VA partnership with a free flow of information to accelerate the pace of research that was coming out of these collaborations. And then I mentioned that there were a number of compelling studies, so I picked a couple that I think are really worth kind of highlighting. Probably one of the strongest studies showing really a causal association was one published out of the Millennium Cohort. I'm highlighting this study as it was one of the few available that really helped us understand the risk of asthma. So this study aimed to longitudinally determine the risk factors for developing asthma, including combat deployment, which was categorized as deployment with combat experience, also people without combat experience, and those who are non-deployed. And so this was done in the Millennium Cohort from 2001 to 2013. A total of nearly 76,000 participants completed a baseline survey and at least one triennial follow-up survey on deployment experiences, lifestyle characteristics, and health outcomes. And basically what we found the key findings were that military deployers with combat experience were 24% to 30% more likely to develop asthma than those who did not deploy. And they saw excess incidence of asthma in them. This association was not seen in deployers without combat experience. And then I mentioned that in some of these military personnel and veterans who have unexplained shortness of breath, despite extensive testing that is either non-diagnostic or in some cases normal, there have been some who have undergone surgical lung biopsy in the past. And I'm presenting some data that Dr. Carleen Kuhl and Dr. Cecile Rose had published relatively recently regarding the spectrum of histopathologic abnormalities we'll actually see in the distal part of the lung, which you'll sometimes hear me refer to as the small airways. And many had more than one abnormality. As you can see, these percentages don't add up to 100%. But as you can see on the left bottom picture, many had moderate to severe emphysema or hyperinflation, sometimes which was not appreciable on chest imaging. And then also the middle picture shows an airway that's nearly obliterated. This is a pretty extreme example of constrictive or obliterative bronchiolitis. And then on the last picture on the right, you can see these areas of purple clusters, granulomas formation consistent with granulomatous inflammation. Also described were peribronchial metaplasia and pleuritis. But I think something that's been actually a little bit more recent that's really compelling is that National Jewish Health Investigators, again, led by Dr. Cecile Rose, and then also Dr. Lowers and other scientists at the United States Geologic Survey, worked together to test the lung tissue samples using sensitive tools to perform elemental analysis of lung tissue, such as scanning electron microscopy and inductively coupled plasma mass spectrometry. And lung tissue samples from deployed military personnel were obtained who had undergone clinically indicated lung biopsies, whereas controlled tissue samples were obtained from deceased donor controls. And the median percentage of silica in lung tissue was 7.3% in deployed military personnel versus 1.8% in controls. And this is of some significance because, as you know, silica, is associated with lung disease and even fibrosis. And so indicating that, many of these individuals, especially if symptomatic, may need ongoing evaluation and monitoring. Also of interest was that there was a high intensity exposure to diesel exhaust and burn pits in the specimens from the deployed military personnel. So with that, I kind of wanted to take a pause here and just mention to you that multiple studies have reported respiratory symptoms and illnesses following Southwest Asia military deployment. Although few of them have been causal in nature, there has been accumulating and compelling evidence that service members deploying to Southwest Asia may be at risk of developing a spectrum of respiratory conditions. So these findings, along with advocacy from patient organizations and veterans groups, helped prompt passing of the PACT Act in 2022. Even prior to the PACT Act, in response to the National Academy of Sciences 2020 report, a VA initiative was started to standardize case definitions and terminology related to deployment-related respiratory conditions. And in this paper that was published in CHEST, a group of experts involving pathologists, radiologists, pulmonologists, occupational medicine providers, public health specialists, and epidemiologists all came together to kind of discuss this and came up with these consensus statements. Some of the highlights from this document were that a 3-tiered approach to diagnosis was recommended that included frontline medical evaluation through primary care. Also referral, the second tier was referral to a specialist to further investigate respiratory symptoms. And then a third tier for the unexplained shortness of breath despite, fairly extensive testing where these veterans and military personnel should be referred to a specialty center. And we'll talk a little bit about some of the specialty centers that are available. And we have a few here in Colorado. And then probably one of the biggest contributions was just this unified terminology to include a spectrum of respiratory conditions that we refer to as deployment-related respiratory diseases, also known as DRRD. And in a previous publication, we actually proposed some case definitions for deployment-related respiratory conditions such as asthma and distal lung disease. Using these case definitions has helped us to more clearly define and study this patient population. So you can see that when we talk about the small airways disease, we had coined the term DDLD, really referring to the region of the lung or the lung compartment where there was injury occurring, and then deployment-related asthma. Oh, sorry. But okay, so now, like I've talked about this DRRD term. So what is the DRRD spectrum? So it really, if you think about the respiratory tract as a target organ, any part of that can really be impacted, from the upper airway, including rhinitis, rhinosinusitis, and laryngeal dysfunction. And then also expiratory central airway collapse, such as tracheobronchomalacia. In the lower respiratory tract, while pleuritis and interstitial abnormalities have been described, there does seem to be a pretty big, large and small airway signal with asthma, COPD, including emphysema, and then bronchiolitis. So let's talk a little bit about diagnostic evaluation and treatment. So these are the medical surveillance findings that should prompt diagnostic referral. So if someone has persistent unexplained cough, shortness of breath, or wheezing, chest tightness, this really deserves another look. And I would argue that a chest X-ray and normal lung function testing are not reassuring in somebody who has unexplained symptoms. Of course, if they do have abnormal spirometry, definitely would want to pursue further evaluation. An excessive decline in FEV1 or forced vital capacity of 15% or greater between pre and post deployment testing is something that would be considered. I have had a handful of patients who had that kind of data available. We've often had to talk to people more about their run times and their physical fitness to get a better sense of this. As I mentioned to you, that lung function testing and that kind of medical surveillance is not typically done currently in the military. So sometimes what we'll hear is somebody was able to run 2 miles in 12 minutes before their deployment. After coming back, they were failing their test or had added on 2 or 3 minutes. So that's what we have used as a surrogate in the absence of some of this information. And while I haven't presented some of this data, what I can tell you is that many people who've had just a non-contrast chest CT scan or lung function testing have had either subtle abnormalities or normal test results, which has really prompted us to think about the diagnostic approach. So the VA has also published a toolkit that includes much of this information, but we would say that on most patients, doing a comprehensive history and physical exam is important, looking any outside records, but really pulmonary function testing, not just limited to spirometry, but also looking at diffusion capacity and getting a sense of oxygen abnormalities or, subtle kinds of abnormalities there may be a little bit more sensitive at picking up some of those distal airways abnormalities. A high resolution chest CT scan with inspiratory and expiratory images can show air trapping, which can also be helpful in identifying abnormalities and can sometimes save us from really going to a surgical lung biopsy in patients. Some additional studies to consider. So in patients who have normal lung function testing but symptoms, I still refer for bronchial challenge and methacholine challenge. We'll consider laryngoscopy if there's concern for vocal cord dysfunction. You can see a number of other studies to look for other comorbid conditions that could be contributing. Another thing, especially in this population, is that, previously healthy group of individuals, sometimes cardiopulmonary exercise testing can be helpful because we can reproduce symptoms of shortness of breath and look for gas exchange and ventilatory abnormalities with exercise. So in terms of chest imaging, we've seen air trapping and central lobular nodularity that can sometimes be helpful. So although it may be hard to see on the screen, panel A shows a CT scan showing some central lobular nodularity, a little bit of tiny little nodules dispersed throughout the lung. And then in panel B, there are some areas that look, more black, or like we would say that indicate air trapping and mosaicism, where there's really this heterogeneity of air clearance consistent with air trapping, which we've seen sometimes could be an indication of bronchiolitis and small airways disease. So Here's an example of a case of severe tracheobronchomalacia. These chest CT scan images are taken from a deployer that we have seen in clinic. He's a never smoker with severe tracheobronchomalacia who worked as an Air Force firefighter with multiple deployments to Iraq, Afghanistan, and Southwest Asia, who developed new onset shortness of breath during deployment. He reported exposure to burn pit emissions and extinguishing fires of burning aircraft. And you can see in panel A, the red arrow, you can see that even on this inspiratory image, his trachea doesn't look quite normal, like it doesn't look circular, almost like a half moon shape. But on panel B, you can see that there's really near total collapse of that on the expiratory images. So sometimes, the issue is the significant impairment is not directly in the lungs, but in the upper airway as well. So kind of moving to the end of the diagnostic part of this, I want to talk a little bit about indications for surgical lung biopsy. Because with this being an invasive procedure, not without risk, we don't tend to do this as much with increasing recognition of these respiratory conditions. But early on, in the case presentations of these individuals, it was really helpful in us understanding risk for disease. So if someone has unexplained and disabling chest symptoms, their other diagnostic tests do not really clarify a diagnosis. Or if they're being treated, I've had patients who are sent to me who've been on prednisone, for months on end with some improvement, but not really, or with no improvement, and looking for kind of a diagnosis. If we're really putting people on empiric treatments like this that have potential consequences, I would argue that having a diagnosis is really quite important. And that the patient needs to understand that the procedure is invasive, painful, associated with risk, and that findings may not inform therapy. It may not affect symptoms or change outcomes, as we don't really have an evidence-based treatment for some of those distal lung abnormalities that I mentioned. That being said, if people have declining lung function or, significant diffusion impairment, getting a diagnosis is really essential at that point. So in terms of treatment, I really just have this one slide, and I was just going to list out all of the conditions here. I mentioned from the upper airway to the lower airway, and you can see that in terms of rhinitis, sinus disease, vocal cord dysfunction, asthma, it's really the standard treatment that we use. I think it's important to understand that, if these are exposure related, because if you are seeing patients who are in the reserves or who may be getting deployed back, preventing them from increased exposure or aggravating their lung disease is important. But apart from that, the standard treatments we use for sinus disease, vocal cord dysfunction, such as like speech therapy and treating other comorbid conditions. And then in asthma, we have a whole host of medications to use, including now biologics. The small airways disease, distal lung abnormalities that I had shown you with those pathologic abnormalities, we don't really have an evidence-based treatment strategy for that. But in severe cases where I do have a handful of patients who are on some systemic treatments, where we've extrapolated some of those treatments from bronchiolitis and small airways disease of other causes. In terms of expiratory central airway collapse, other than treating underlying risk factors and lung disease, unless it's really severe or there's severe tracheal collapse of 90% or more, we don't really consider surgical management. So that's what I would say about treatment. But now I kind of want to, the last part of this talk about what we should be thinking about moving forward. So I'll talk a little bit about current and future research, briefly go through some of the non-invasive diagnostic testing and novel treatments. So non-invasive markers of deployment-related small airways disease are really needed. As I mentioned to you, spirometry or traditional lung function testing often misses these diagnoses, and we don't want to be sending people to surgical lung biopsy, and we're doing that much less frequently now. Sorry. Okay. So we've over the past, I would say, decade, we've looked at lung clearance index, a parameter that's measured via multiple breath nitrogen washout. And we had looked at this in a group of military deployers. We found that deployers with DRA or deployment-related asthma and deployment-related distal lung disease, or this distal lung disease I mentioned, were significantly more likely than controls to have an abnormal LCI score via this multiple breath washout. And this was adjusting for sex, smoking status, and BMI. Deployers who reported more frequent exposure to explosive blasts had significantly more abnormal LCI scores. Sorry, I keep jumping here. So there's also this other technique that many of you may know, like, or for people who are in med peds, called oscillometry. So the emerging use of oscillometry in detecting small airways disease is really an area of interest, I think, in asthma and other lung diseases. This is a technique that transmits sound waves and then measures airway resistance in response to different sound wave frequencies during normal breathing. The nice thing about it is that it involves passive breathing rather than forced maneuvers used in spirometry. And anecdotally, we've noted that many of our military veterans, active duty service members note that this is a much easier test to do than traditional lung function testing. Not something to replace it, but that can really complement it and help us detect maybe these distal lung abnormalities in conjunction with other abnormalities. Actually, the first reference I have on this slide talks about abnormal oscillometry parameters and a high and more frequent abnormalities noted with oscillometry than with traditional lung function testing in a cohort of symptomatic veterans out of the East Orange, New Jersey VA, which is also the site of the VA Center of Excellence on airborne hazards. Okay. And then moving to chest imaging, quantitative chest imaging may also help identify subtle abnormalities in distal lung disease. So there's been a technique called parametric response mapping. It's a computational analytical technique applied to high-res CT scans that has proven effective at identifying and quantifying small airways abnormalities in patients with COPD and post-transplant bronchiolitis. PRM quantifies the percent of lung tissue affected by functional small airways disease. And then on the right-hand side, you'll see from some of our colleagues at National Jewish Health, led by Dr. Rose and Dr. David Lynch, another type of technique looking at something called PI10, which looks at the airway wall thickening calculated by taking the square root wall area of an airway with an internal diameter of 10 millimeters. But anyway, what I would say about this is that deployers were more likely to have some of these subtle abnormalities using this parameter on quantitative imaging analysis too. So not quite ready for prime time, but something to look for potentially in the future. And then one other thing I would say here is that, you know, the longitudinal health effects of patients with deployment-related respiratory diseases, and particularly in DDLD, are kind of unknown. But Dr. Zellbaron at National Jewish Health and our team had looked at this, and we have reported in our cohort at National Jewish Health, which is active duty military personnel, some of who've transitioned to the VA, more intense inhalational exposures were linked with lower post-deployment lung function. Those with distal lung disease experienced significant longitudinal decline in their FEV1 FVC ratio, but other DRRD diagnosis groups did not. And I think this is an important thing, hopefully, for public health, you know, officials to kind of think about, to consider baseline spirometry for those likely to face combat and those involved in infrastructure or burn pit duties where risks appear highest. Although we think that we have stopped kind of sending military personnel to some of these regions, as I mentioned, we still have an ongoing presence, and there still are men and women in harm's way. So this is a little bit about our current clinical research studies in post-deployment respiratory health. One study that I'm excited to talk about is something called the SEAL study. The PI of this is actually Dr. Fernando Holguin, who's here, so he can correct me if I get any of this wrong. But I think one of the exciting points of this is that this is really a collaborative study that's an example of us leveraging expertise in multiple institutions. This is a study to improve deployment-related asthma by using L-citrulline supplementation, which we refer to, again, as a SEAL study. And Dr. Holguin and Dr. Sharma have published the utility of L-citrulline supplementation as in non-obese or in obese asthmatics and or T2 low asthma as something that is potentially, promising. And so as a substantial number of veterans with deployment-related asthma have non-TH2 asthma endotype with suboptimal asthma control, like most of our asthma therapeutics are really linked towards the T2 high asthma, we need some novel therapeutics. So we plan to enroll 75 study participants, and we're actively recruiting and enrolling now. Oops. Sorry. And so some of the things we'll be looking at are asthma control, FeNO, and then lung function. So excited to hopefully share those results at some point in the future. And it's also one of the first clinical trials in military or in veterans with these exposures. So that's something exciting. We've spent so much time in the past 3 decades trying to identify what the abnormalities are. It's exciting to now start to segue into thinking about treatment and prevention. And then in terms of some of the other DRRD research studies, I just want you to get a general idea. I have been building a cohort of veterans, both controls and symptomatic veterans with lung disease at the VA, as you can see in the first 2 studies. Doctors Momita Ghosh and Dr. York Miller are doing a bronchoscopy study, trying to get a little bit more at the getting mechanistic insights of epithelial repair and dysfunction in those with deployment-related distal lung disease. And Dr. Shelley Forbes is looking at high intensity interval training to improve symptoms. This is something that's of a key importance to many of our military veterans. They're not often as active as they used to be, but they're not meeting criteria for pulmonary rehab with end stage disease. So helping them with functional outcomes. And then Dr. Gupta is looking at mitochondrial injury and mitochondrial dysfunction in those with deployment related respiratory disease. Something that could potentially tie more than just the target organ of the lungs. So in thinking about research needs and priorities, I think you've heard me talk a lot about exposure assessment. Still, I think this is an opportunity for us to do this better in the future if there are opportunities for that. We need large epidemiologic studies of respiratory outcomes, standardized questionnaires and multi-center studies, further validation of non-invasive markers of lung disease, both the oscillometry and multiple breath washout, as well as quantitative chest imaging, better understanding of the DRRD pathogenesis to inform treatment, so more partnerships with basic scientists and mechanistic work, a longitudinal follow-up to assess prognosis, linkage of exposures to health outcomes. And then as an occupational medicine provider, I can't stress how important prevention is. It's difficult to see patients on this side at the VA or at National Jewish Health. So I think targeting high-risk settings for realistic exposure control is important. In terms of thinking about exposure assessment and control, thinking about real-time monitoring and maybe biomarkers of exposure, some priorities for research or looking at the different types of exposures from PM 2.5, burn pit smokes, jet fuels, diesel, other occupational, what we call vapors, dust, gases, and fumes, and just potential effect modifiers that may also be contributing to the disease. Linkage of exposures to health outcomes may be coming in the future. The Department of Defense and VA are launching this thing called the individual exposure record, or have launched this, where this should provide more information about individual level exposures. Although there's not that much data at this time, this is something that could be potentially helpful and, a lesson learned from what we've had to deal with for the past few decades. So I wanted to, before we end, I'm getting near the end at this point, but I just wanted to mention that in terms of what this may mean to you, especially if you're not at the VA, we've had a drawdown leading to a drawdown of active duty military personnel, and many people are transitioning to veteran status. But as you know, the VA healthcare system has been inundated, and many individuals don't live near a VA healthcare center, so they're seeking healthcare at places like University of Colorado and other community providers. So you may be evaluating patients who've had some of these exposures. So just kind of thinking about some of this, if you're seeing someone with some of these respiratory conditions, and asking a little bit. Here are some of the resources that I think could be helpful as you potentially evaluate patients. I don't know how many of you have heard about something called the VA Airborne Hazards and Open Burn Pit Registry, but this is an online questionnaire that links veterans to an opportunity to participate in evaluation that is free of cost to them. So I've included some links on that. We also have specialty centers across the U.S. One of them is here in Colorado, and there's also a Center of Excellence in Deployment Lung Disease at National Jewish Health, where patients can be seen for more extensive evaluation. There's something called the Deployment-Related Respiratory Disease Toolkit, and this is something that if you do see many of these patients in your practice, it's worth bookmarking this link, but it has sort of many of the suggested tests that I had recommended earlier. And then this is included in the diagnostic toolkit, but these are some sample questions. So thinking about military exposure history, what branch people served in, their specialty codes and run times. Also asking about where they've deployed to, especially if it's Southwest Asia, and then some of these other exposures that I've sort of mentioned. These can easily be created into a template. So some of these symptoms. And then the last slide I have here really is there is something called Vet Home. And I think this could be helpful, especially if you're wondering about things outside of lung respiratory health effects. But there's this new VA program using telehealth to serve veterans with military environmental exposures. So it's called Vet Home. It's actually headquartered here in the US, but is really serves the entire nation. And they conduct free registry evaluations for everything that you see listed below. Airborne Hazardous and Open Burn Pit Registry is really one of their big is really a big focus for them. And if you have other questions, like either as a veteran or as a healthcare provider, like what should I be thinking about? You can actually call this phone number or go to their website, and there's options where you can speak to providers to get some guidance on this. So as they build this out forward, this may really be a helpful resource to have. And then in terms of take-home points for the clinician, having an increased awareness of the spectrum of disease is important. And remembering that's not just one disease, it's really a spectrum of conditions. The clinical history medical findings that prompt diagnostic referral include not just symptoms and abnormal spirometry, but an excessive decline in physical fitness. The recommended approach to diagnosis needs to be tailored to each patient. Medical treatment plans should be customized for each patient. But there's no evidence-based pharmacotherapy for the small airways distal lung disease, such as bronchiolitis. And if you see a patient who's eligible to enroll in the VA Airborne Hazards and Open Burn Pit Registry, provide them with that information or with that link at va.gov. With that, I just wanted to acknowledge a group of our clinical and research teams that have helped us as we have tried to understand more about this disease. And I'd like to end by thanking all of our service members and contractors who've served. With that, if there's time for any questions, I'm happy to take any.
Thank you, Dr. Krefft. That was a terrific talk. And I think we have a few minutes for questions. Dr. Banish.
Nope, a great talk. Thank you very much. Thanks for your work. Two questions that are related to one another. You touched on prevention at the end of your talk. Can you hear me?
I can't hear. I
Yep.
think you said two questions, something about prevention.
It's a terrific talk before that, but two questions. Prevention, how feasible is it? It does seem like that, military personnel that work in or near burn pits, for example, could be encouraged to wear respirators and things like that. Is that being done? Hopefully, people that are in known high exposure positions, are they wearing some kind of respiratory protection? And then secondly, I guess in people that work in occupations where they're exposed to radiation, they wear a dosimeter or something like that, and track their exposure. And I think you touched on this just a little bit too, but is it possible to track in real time somebody's exposure to particulate matter? And would that be of value?
So those are both excellent questions. And I think something that, I think is still really important for us to address. The first one you mentioned, prevention, in terms of things like some common sense things about burn pits. So what we had heard, more than like a decade ago was that people were sometimes doing exercise or running around the burn pit. So there are some basic things that could be done in terms of prevention, like exercising indoors or maybe not having your daily physical fitness kind of routine around burn pits. So there have been some, I guess, administrative changes in terms of that. And then also the military has moved towards not using burn pits. So moving more towards incinerators. That being said, we know that still there's, burn pits are not the only kind of source of combustion. Sometimes there are small burn barrels where people's waste, especially in smaller outposts, maybe they don't have something like an incinerator, the incinerator breaks down, or waste, disposal services is still being burned, often with diesel or jet fuel as an accelerant. So while widespread burn pit use has definitely decreased, and there's still definitely exposure to trash burning. But I think that we've seen some changes in that regard. In terms of some of the things you're talking about with personal exposure monitoring, both maybe from a radiation standpoint and some of this particulate matter, I feel like this is definitely possible. There are definitely devices available for this. And, as someone who's been interested in other types of occupational lung disease, these real-time exposure monitors are, I would say that from what we've heard before in the past, it's not mission central and may not be the first area of concern when, especially during a combat operation. During some of these peace type operations, we'd hope that there would be some of these opportunities for prevention, or at least, considering this kind of sampling in high risk groups or high combat or people who deploy over and over again. So I think it's something that we should continue to recommend and push towards, along with medical surveillance. Like, while spirometry may not be that sensitive, I mean, I think of it kind of like in the ICU, maybe central venous pressure monitoring is not helpful, like as a snapshot, but sometimes that dynamic assessment and more than one value in the trend can be helpful. And so those are areas maybe for secondary prevention, I think.
Thank you. One last question are you sure? Okay. Thank you so much for your talk today. We really appreciate you being here.
Yeah, thank you.